Thank you, sir. At the outset, I'd like to thank Dr. Satyan and the Scientific Committee of AIOS for providing me this opportunity. Ocular surface disease is very important, especially when we start practice of glaucoma. And I'll just take you through the epidemiology and what causes ocular surface disease in the general population. This is my financial disclosure. And the ocular surface actually functions as a single unit, and the unit consists of a tear film, the corneal epithelium, limbal epithelium, conjunctiva with its epithelial cells and goblet cells, the eyelids with their meibomian glands and mucoepidermal junction, and the lacrimal gland. They are basically an anatomic continuity, and they share a feedback mechanism. And as a single entity, they also react to external stimuli. And the tear film is one of the most important structures of the ocular surface. It covers the ocular surface and it's continuously cleared and replaced. In this manner, it is also very dynamic. It's very important for ocular health because it's the principal refractive interface, lubricates the ocular surface and supports cells of the ocular surface, and also acts as a defense against microbial invasion. And if you look at the microscopy of the tear film, it's a trilaminar structure. The outermost layer is the superficial lipid layer. The in-between layer is the aqueous layer, which is secreted by the main and accessory lacrimal glands. And the innermost mucin layer is secreted by the goblet cells. And this mucin layer helps to attach the microvilli of the corneal epithelium to the aqueous layer. So dry eye, as defined by Deuce in 2007, International Dry Eye Workshop, says that it's a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. One of the earliest studies which assessed dry eye was the Salisbury eye evaluation, in which 420 patients were evaluated. Most of the patients were females of age more than 65 years. White patients comprised 74%, and a questionnaire survey was done on these patients, and 6 symptoms were assessed: dryness, grittiness, burning, sensation, redness, crusting on the eyelashes being stuck. 41% of the patients reported no symptoms. One or more rarely patients reported, 45% of patients reported one symptoms. And 14% had one symptom very often. The second study which evaluated dry eye was the Beaver Dam study, and this was done earlier than the Salisbury eye survey. The patients included were in the age group of 48 to 91 years. 43% were male, that is 57 were female patients, and the overall prevalence in this study was 14%. And the prevalence varied from the in the age group they were studied. Less than 60 years, the prevalence was 8%. More than 80 years, the prevalence increased to almost 20%. Women were more affected with ocular surface and dry eyes than men. And other systemic factors affected, and the lifestyle also independently affected the dry eye disease in this group. A woman health study and physicians health study was conducted in the US, and they had almost in the women health study 40,000 health professionals aged more than 49 years, and dry eye disease was diagnosed in 6.7%, and severe symptoms were present in 3.2%. Similarly, the physicians health survey, in which 22,000 US male physicians were assessed with the average age of more than 55 years, dry eye disease was diagnosed in 2.3% of patients, and 1.9% were suffering from severe symptoms. Another study in Australia, in which 962 patients were included. This was also a questionnaire survey, and the definition was mild, moderate, severe, nil, mild, moderate, severe dry eye disease, and out of which 5.5% had very severe symptoms of dry eyes. So in various countries, the usual prevalence is approximately 1.5 to almost 30%. The prevalence of dry eyes. In India, Sahai Eye Hospital conducted a survey in which the prevalence rate was found to be almost 20%. The problem with dry eyes is there's a very wide prevalence in rates. There's no consensus on diagnostic criteria, and there is always disparity between signs and symptoms. And each study uses a different definition. It's generally underdiagnosed because dry eye disease is considered to be part of growing older. And older people generally tolerate dry eye far more longer than young patients. So what happens in glaucoma patients? Just present two brief slides. One was by Fechner et al., published in Cornea 2010. They studied 630 patients, a multi-centric study. Mild OSDI symptoms were present in 20%, moderate in 13%, and severe in 13% of patients. And if the patients were on single medication, the OSDI score was 12%. Two medications, the score was 16%. And three medications of glaucoma medications, the score was 20%. So you can see as the number of medications increases, the patients become more and more symptomatic. Waindrup again published in 2008 a cross-sectional study, and they assessed OSDI. Almost 60% had symptoms in at least one eye. And with each benzalkonium containing eye drop, the odds ratio jumped by 2 for developing dry eye disease. So what are the etiology and pathogenesis of dry eye? The most important thing is tear evaporation and inadequate tear secretion, and tear film instability in all stages of dry eye disease, and definitely there's a role of inflammation in dry eye. So what happens is there is inadequate tear production or increased tear evaporation. This leads to hyperosmolarity, leads to inflammation, ocular surface damage, altered tear film disturbance, and this again produces a vicious cycle of increased evaporation and inadequate tear production. Factors which influence dry eye disease are decreased tear production, especially around the 6th decade of life, menopause and post-menopausal women, sex hormone influences tear secretion, meibomian gland function, and conjunctival goblet cell density. Also, chronic androgen deficiency can also affect meibomian gland dysfunction. Other factors include long-term contact lens wear, use of systemic medications, ocular medications such as atropine which has sympatholytic activity, and laser procedures. Dietary factors such as smoking exacerbates dry eye. Intake of omega-3 fatty acids reduces dry eye symptoms. Lifestyles, extended use of extended visual tasks like computer use, prolonged reading, TV watching excessively, they all exacerbate dry eyes. And there is diurnal exacerbation of dry eyes depending on the activities done at home. Climate also has an important role to play, especially the relative humidity, indoor environment, pollution, air travel, etc. Low relative humidity increases dry eye disease, especially in air-conditioned cars or air-conditioned environment. Indoor air has to be kept dry and cool with a relative humidity of 40% to avoid this. Functional dry eye is another entity in which the tear film has normal layers, but there is an abnormality in the lid ocular structures. Inferior lid laxity, ectropic lid margin, incomplete lid closure, decreased blinking frequency, or incomplete blinking. Inflammatory basis of dry eyes is a very important study area nowadays, and a lot of studies support anti-inflammatory therapy, especially drugs like cyclosporin. Promoters of inflammation, they decrease secretion of natural anti-inflammatory factors like lactoferrin, and it leads to increased pro-inflammatory cytokines like IL-1, IL-6 and TNF, and this leads to hyperosmolar tear film pro-inflammatory stimuli. This leads to expression of immune activation and adhesion molecules by the conjunctival epithelium. There is increased matrix metalloproteinase activity, which leads to deranged corneal epithelial barrier function, increased corneal epithelial desquamation, and corneal surface irregularity. Simultaneously, there is apoptosis of goblet cells caused by cytokine TNF-alpha. So, inflammatory mediators, especially in conditions like rheumatoid arthritis, they cause altered secretory dysfunction by the lacrimal gland, meibomian gland, lead to hyperosmolar tears. Ocular surface epithelial disease and ocular surface inflammation causes release of cytokines and chemokines, affect the adhesion molecules, T cells, matrix metalloproteinases, and apoptosis of goblet cells. So all these triggering factors, destabilization of the tear film, underlying condition, dysfunction of main lacrimal gland, meibomian gland, all leads to a cellular disorder leading to dry eye disease. So, thank you.